So a few months ago, I got a letter from the HSC telling me that it was time for my free cervical exam to detect HPV, potentially prevent cancer. And like a lot of people who got this wonderful news, my first reaction was, don't make me do it. Now, I've studied public health. I've worked in health tech and health departments for years, trying to do very similar things, trying to get people to do something that will improve their health and make them live longer and healthier lives. So logically, I knew this was something I needed to do, but emotionally, I don't want to do it. Now, if everyone behaved logically and by the book, a lot of people in public health would be out of a job, because it's basically the practice of getting people to do those things that will make them live longer and healthier lives, those logical things, and having those people, all of us, say, nah. So how do we do it? How do we get people on a large scale to change their behavior, to stop doing something or start doing something that sometimes they really, really don't want to do? So I'm going to talk about two things today that can add some humanity to your design and your work, and how you can actually integrate them in a way that can help you move faster. So the first one is barriers. What barriers are people up against? And the second one is the people around them, the community, that little bit of peer pressure that we can use. So in design, a lot of times when we talk about friction, and that's something you can kind of smooth away. And a barrier is something that is a blocker. You need to dismantle it, you need to climb over it, you need to go around it. And a lot of times there's one waiting right behind it. So in the case of that letter from the HSC, because of the national program, my test is free. So they've taken care of the cost barrier, but how easy is it for me to get to the appointment, to make an appointment, to find an appointment at a time that works for me and my life and my work and my family? I have two very needy cats. So we need to take all of this into account, all these shades of people's lives and all the barriers they might be up against, whether they realize it or not, and whether they can do something about it or not, and if they realize they can do something about it or not. And the second thing is people, the community, that peer pressure that can help us go over those barriers, and a lot of times dismantle really big health disparity level barriers. There's been over 30 years of research showing that when you train hairstylists in African American and Afro-Caribbean communities to be health educators, you get as much as 3 times more people getting screened for cancer, taking action to prevent HIV, learning about heart disease and diabetes. And we can also think about how can we help people engage with their community in healthier ways. So this is a recipe for fry bread, which is a traditional Navajo food. It's put out by the Indian Health Service in the US. And in this case, it's made with whole wheat flour. So it's helping people engage in tradition and community without compromising on health. So these were nice stories, but how do we actually put it into practice? So the good news is that public health loves a good behavior change model, and they can be really, really easy and quick to integrate into your daily design and research work, so you can get moving on those. The first one is the health belief model. It's one of our foundational behavioral change models, and it takes into account a lot of things that you're probably already thinking about or taking into account a lot of things I talked about today. And notice that it says perceived next to a lot of these. If I don't think the risk is big enough to me, if I don't think the benefit is big enough, if I don't think there's a barrier there or that I can do something about it, I'm not going to actually change my behavior in that direction. So we need to be thinking about what's the context of the person and what things might be affecting them. The second one is the COMBI model, which stands for capability, opportunity, and motivation, and those come together to enable the action and the behavior that we actually want people to take. So am I capable physically and psychologically, meaning do I understand how to do it? Do I know how to do it? Do I have the opportunity in terms of accessibility and finance and resources and time? And also, what's my motivation? Both external motivation coming from the outside and my internal emotional motivation. And finally, we have the trans-theoretical model, or the stages of change model, which is this circle that we're always on when it comes to behavior change as we're thinking about it, engaging with it, maintaining it, and going all around those stages. And it can be really, really helpful if you're designing for habit building, but it can be also useful to think about where people are on that circle as they're maybe encountering your work for the first time or engaging with it over time. And what ties all of these together is expanding our lens, looking beyond just that person and the action that they are doing or not doing, and thinking about what's standing between them and that action, and what other people are around them helping them take that action. And I'll leave you with this. Talk to real people, not synthetic users, because only they can give you that enrichment and those other shades of humanity that can really help you create designs and solutions you would have never imagined. Thank you.